So hi, everyone. I'm Danielle Rankley. I'm a project coordinator with the UMTRC, and I'm so happy you all could join us today. So today for our telehealth role in outreach care in the interdisciplinary setting webinar, we are joined by Samantha Cassisi, who is a licensed and certified genetic counselor with Michigan State University. And Samantha is she currently specializes in pediatric oncology, bleeding disorders, and cystic fibrosis. Samantha went to school at the University of Arkansas for medical sciences and spent time in clinical rotation in locations such as Omaha and Australia. So Samantha's passions include interdisciplinary care and lifespan care for those with hereditary conditions. So I will let you get started, Samantha.
Thank you so much. I really appreciate it. So let me see if I can get my screen shared and the PowerPoint pulled up here. Does that show the PowerPoint?
Yep, looks good.
Great. So today I'm going to be talking on telehealth's role in outreach care in the interdisciplinary setting. Again, my name is Samantha Cassisi. I'm a licensed and certified genetic counselor at Michigan State University. Couple objectives, be able to apply new telehealth models to current clinical practices. So we'll go through a couple different models that I've seen. Understand telehealth's role in reducing regional disparities, and then learn to navigate telehealth in an interdisciplinary setting. Okay, so first, what is outreach? Outreach services is the type of health services that mobilize health workers to provide services to a population or other health workers away from the location where they usually work and live. So this provides health services to any population who might not otherwise be able to access these services, and they include both direct and indirect delivery methods. You can educate target populations, educate providers, deliver services. There's a number of different things that you can do with outreach. Some benefits of outreach: to identify underserved and underdiagnosed patients, look at accurate numbers of affected people in rural areas or areas that wouldn't otherwise be serviced. Support advocacy for treatment and services, educate newly identified patients and old ones, build patient community support and advocacy networks, build collaborative relationships with the medical community, and raise awareness for, specifically, we were working on bleeding disorders, but this could be any condition that you're working on. Importance of outreach. So for patients, you get access to specialty care and comprehensive clinical care and research, improvements in the quality of care and health outcomes, and then cost and time savings. Patient satisfaction is also quite high with telehealth and outreach. For healthcare providers, you can decrease professional and personal isolation of remote providers, coordinate and promote the working together between specialists and the primary caregiver, help with providing state-of-the-art and guideline-based therapies, and then also improves retention of remote providers because of that isolation piece, and it motivates them to remain where they're at. Society-wise, decreases cost of care, can decrease the use of the emergency department, and then plays an important role in public health by providing surveillance, assessment, and preventative services. So I want to start by talking about Michigan and MSU. For those of you who are unfamiliar with what Michigan looks like, I've provided kind of a photo there. We are the little mitten state, and then having a lot of rural areas, particularly in the Upper Peninsula, that might not be serviced by typical specialty care providers. So you can see in some of our key areas just how far away it would be for us to travel from Lansing in the middle of the state all the way up to some of these areas. And we can either drive or fly up there if we're going to be going in person. There are a couple different clinical sites and a bit of a history for each of them. First, Marquette General Hospital, I believe, and I wasn't, here at MSU at the time, but the reason for telemedicine to begin with was inclement weather surrounding their typical outreach where they would go up there and see patients. So the provider on site was a physician's assistant, and then the MSTU team consisted of a physician, social work, and then a nurse. Comprehensive team members on site were a physical therapist and genetic counselor. As time went forward, we saw expansion of this telemedicine in different areas of the state. And you can kind of see, again, one way how far away these places are, and who was kind of there on site to help us out. These would be situations where the patient would come to a doctor's office or a pediatrician's office, and that would be the coordinating center, essentially. That center would, have internet set up, have the telemedicine ready, and the patient would be able to see our specialty providers at that point. Now, one of the main things that I wanted to kind of reiterate is the cost savings for telemedicine. So in total driving costs, clinic costs with flying, if we were driving, you can see that costs for telemedicine are significantly less. And so that's just one of the huge benefits, and you can see that very easily in this slide. I wanted to also give a couple examples of why this outreach to these rural areas are important. Now, this isn't bleeding and clotting, but this is data pulled from Michigan's MDHHS website. They track patients who are seeing a cancer genetic counselor, and as well as patients who have a cancer diagnosis. And what they saw was certain areas of the state had low utilization of cancer genetic counseling services, even though they had a high need for genetic counseling. So this is, one example of a specialty service that could be administered to these areas that are seeing this low uptake due to the fact that they're rural. This is another example. 7 counties saw a high need for genetic testing, but had few residents utilizing the genetic testing services, as reported by the Hereditary Cancer Network in the state of Michigan. So just kind of another example of why this is so needed. So I was kind of looking through some of the data, and the National Cancer Institute did a looked at 51 comprehensive cancer centers that have large interdisciplinary teams and act as community hubs for cancer care in that region. They were noticing that patients had to travel to the location, causing disparities in those of poor socioeconomic background and rural areas. So they were also reporting that there were higher incidents of death compared to urban counterparts. So this is a prime example of where telehealth had the potential to support patient care. There's kind of 2 main ways for telemedicine to help out. asynchronous and synchronous. Asynchronous being image transfer, MRIs, monitoring of things like blood pressure, blood sugar, weight tracking, that sort of thing. And then for us in the Bleeding and Clotting Clinic, we also have bleeding logs, and we have been trying to get telehealth or rather technology to help us out with these bleeding logs so that we would know more in real time when patients are having bleeds, how severe they are, what they're treating, things like that, and make sure that they're contacting us in these cases. And then synchronous would be typically what you would see for a real-time telehealth appointment. There's a lot of different ways that the what they call the originating site can be located. You can see it in a specialty clinic, primary care office, even in the patient's home. You can see it in an inpatient setting, and then even international consultations as well, being seen and utilized by telemedicine. So this is coming forward to different models. I wanted to share two main models that MSU Center for Bleeding and Clotting had utilized, as well as what I had seen in my training. MSU Center for Bleeding and Clotting sees patients in Lansing, as well as a number of other locations where they will travel there to be in person and deliver those services. However, there are instances where we don't travel. So if there's inclement weather, sometimes there are lack of seats on the plane or the vehicle that we are taking, or if a team member is just unable to travel, but would be maybe available for clinic if they were able to do telemedicine. How does this look? How does this model look in a busy interdisciplinary clinic? So we use an EMR called Athena, not necessarily as robust as maybe Epic, but Athena does have a chat option that we can add members to the chat. So essentially, whoever is going up to the site, along with the person who is doing telemedicine, are all added to a single Athena chat. And then a computer or a laptop is used designated for that team member. So then the computer is moved from room to room, just like the team member might be in person. Instead, they are moved by the people who are there in person. So if I was telemed, maybe the dental hygienist or the social worker might move me into a room where I could then talk with the patient, complete my portion. And then when I'm done, I would just Athena text the group, hey guys, I'm all completed. And someone would come and move the computer back to the team room where the person can await their next patient. The next one I wanted to go through is University of Arkansas for Medical Sciences Angels program. So this is for prenatal cases. It's a consultation service with a wide range of physicians, different specialties, genetic counseling is involved, they do an ultrasound right there, telemed at the visit. And all of these things are all kind of coming together to create a like a comprehensive experience. And I want to see if I can bring this up. I'm not 100% sure. I might have to stop sharing and share again. Okay, so I think that you guys can see the website now. I wanted to share this video and I'm hoping that the sound comes through.
A high-risk pregnancy really is a very broad term. Ready? Yep. It can be anything from things that affect the mother during pregnancy, such as medical conditions that could affect that pregnancy, chronic hypertension, diabetes, could all at some point become high risk. It could also be with relation to the fetus that's growing inside. There can be complications with the fetus where it's not growing nearly as we would expect it to, or there's other conditions that we see throughout the pregnancy that can lead that pregnancy to become high risk.
We use telemedicine in high-risk OB in several ways. One of those ways is in consultation with a maternal-fetal medicine specialist. A patient that lives in a rural part of our state can access our maternal-fetal medicine specialist here at UAMS over televideo and through telemedicine. We also use it in the setting of teleultrasound. So a patient that needs a high-level ultrasound can get that ultrasound locally in a rural part of our state, close to their home, and that ultrasound can be reviewed live by our maternal-fetal medicine specialist.
Different pregnancy complications.
They also have access to a genetic counselor at the same time that provides information and counseling regarding prenatal testing and prenatal screening for their pregnancy.
Hello. Congratulations. Thank you.
We look for a lot of markers that would have normally associated with a baby that has a chromosome abnormality. And we didn't see any of those markers today. And so that's reassuring.
Yes, it is. Providing access throughout the state is extremely important. We have 39 delivering hospitals in our state. Some of those areas are extremely difficult to get to. There are very few providers. And so therefore, by being able to go to them where they live, by being able to consult with them and their doctors, and making this a much more easily accessible process helps improve the healthcare of women throughout our state.
Okay, let me see if I can bring up the presentation again. Perfect. So as you can kind of, some of the things you could see, even if I'm not sure how well you guys were able to hear, but what you could see was that people were in the different areas of the state all being brought together. And the nurse practitioner, when I was there able to observe, is like the wizard of the entire operation. She's able to bring in the interpreters, the genetic counselors, the different doctors, view the ultrasound, interpret the ultrasound, and speak to the patient about it herself. And all of these things are kind of all coming together. And she's basically putting people live, telemed wise, into to see these patients. So the nurse practitioner is kind of the coordinating hub, and all of the other pieces fall into place. So that's just another way that interdisciplinary care can work, is having one central person coordinating everything, and then everybody else kind of coming in from different areas of the state and being able to provide care to the patient. Angels provides many services, weekly real-time telemedicine conferences. So that's an educational piece that is able to be accomplished, real-time ultrasound readings, training for local technicians, 24-hour call center service for physicians, and then a call center available for women with questions. So all of these things are able to be provided via telemedicine. Some challenges. So lack of physician, nurse practitioner, physician's assistants at the originating site to participate in these telemedicine visits can be a challenge. If, say you're just seeing the patient in their home, that might be a little bit more difficult than having a practitioner there to kind of help coordinate things. Inability for the doctors to actually feel or palpate what's going on. that can be difficult. Although there's future technology coming into play where that maybe wouldn't be as big of a problem. And then, of course, being able to purchase some of these things can be difficult, costs of the equipment. So if if you're using, these tactile feedback mechanisms, how expensive that would be on initial uptake. You have to rely on technology. Internet is a necessity. So what if the patient doesn't have internet and they don't have the ability to, maybe get to a doctor's office that would have internet, or we don't have the relationship with the local PCPs to where the patient would be able to go in. What if there's internet issues that particular day? What do you do then? Those are some of the things. Depersonalization. So these, you're not seeing the patient in person. So this could be a little bit difficult for the patient to make that connection. Confidentiality, HIPAA, privacy, all of this is solved by HIPAA compliant platforms. However, you do have to pay for those platforms. So again, that's some startup cost to think about. Any cultural or linguistical differences, you'll have to make sure that any of your interpreters, how you would normally do things, maybe bringing in an interpreter, or some people have like a machine that is specifically for their interpreters. That's not necessarily something that is going to work in this setting. So you have to kind of plan that out. And then what international telemedicine would look like, that's still something we're not 100% sure on. Okay. I know this is a little short, but I want to leave time for discussion as well. And I also want to hear about what some of the current practices or current things that are going on for you guys. Here are some of the references I used. With special thank you to Roshni Kulkarni for sharing some of the slides related to the history of MSU telehealth, which she knew a little bit better than I did. Okay, so let me see if I can bring this up here. What sort of questions are there related to the kind of the telehealth models, or anything that I discussed here?
And you can go ahead and put those questions in the chat.
Yeah. Or if you want to share like what some of the things that your clinics do that's a little bit different or the same, I'm super interested to hear about what is going on out there.
So something that I'm curious about when you're working with those high-risk pregnancies and that kind of thing, do you see more of that occurring in specific populations, or is that something that's like ubiquitous around your state? Is that something that's occurring specifically in like rural populations, or do you see that equally everywhere?
So this was in Arkansas that they were doing the OB visits, and essentially they were utilizing this in rural areas specifically, as well as really anywhere around the state that needed specialty care and didn't have access to it. The patient would be able to come into their normal doctor's office, if where there was an ultrasound machine set up, and get the specialty care that they needed. So this kind of helped out, especially if they didn't have or they had difficulty with transportation, or didn't have the funds to be staying overnight at a hotel somewhere just for a single visit. So that was kind of the model that they were using.
Right, because I know we see such a lack of that specialty OB care. So that's a really interesting way that you could go about sort of getting over that barrier.
Yeah, and this one was really cool because the coordinating nurse practitioner, I mean, I'm telling you, she was amazing. She was able to bring in all these different specialties into, and her entire, you sat down and you looked in front and it was just screens and screens and screens. And each screen had a different patient in front of her and she could click on each of the screens. She was handling multiple patients simultaneously and putting in different specialties in to see the patient as she, at the same time that she was talking to another patient. And so that was just really cool to see.
Yeah, and I think that really plays into, we talk about how when you want to successfully implement a telehealth practice or telehealth program, you need somebody who's one really strong advocate. And so having somebody like that specific nurse practitioner who had like that passion and that ability to do that, that's how you get a telehealth program going.
Yep. Yeah, exactly. And then I threw in kind of things that we do, and we also see at the Bleeding and Clotting clinic, we see patients on a regular telehealth basis. So sometimes, if we're doing a comprehensive care visit in Lansing, we'll almost do it the opposite, where instead of the practitioner being on the computer going from room to room, the patient's on the computer is just sitting in a patient room, and then each of us will go in to, just like it's a regular patient visit, we'll go in and see the patient. So you can kind of flip-flop it too, and it fits into, what's really nice about that is it fits into a normal comprehensive care model, so or a typical comprehensive care model rather, where our clinic, it has not changed. We are seeing patients the same way. However, it's almost like a mixed model. Some of our patients are inpatient, some of our patients are telemedicine where the computer is set up, and we're able to just see more patients that way.
Do you see more of one than the other?
Usually we see a lot more inpatient, but telemedicine is definitely an option. We also, our current model is for us to travel to those locations. So like this week, we'll be going over to the west side of the state to see some patients. But, again, if one of our team members couldn't make it, instead of just telling the patient, sorry, you can't see physical therapy today, maybe the physical therapist has a couple hours out of her day where instead of taking the entire day to travel there, see the patients and come back, she could just take part of her day to see the patients over telemed, and then whatever other obligations they had, they could do. So we've also utilized this if somebody is ill but not like ill enough to not work, like they got like a small cold or something like that, they would see patients over telemedicine.
See, that's really interesting to me because I hadn't thought about the prospect of doing a mixed model where like you have different providers coming in. Like that's really cool. I like that.
Yeah. So it really works out for us.
So do we have any questions from the chat at all? Nope, I don't think so. So if you don't have anything else to add at this time, or anyone else has anything to ask. Oh yeah, one more thing. Sorry, I just keep thinking of things I want to talk about. But so data collection, how does that work when you're collecting data to look at the sort of efficacy of these programs? How do you go about collecting that data?
So a lot of it, so in terms of like patient satisfaction and stuff like that, are like survey results that we're able, and we use that as part of our quality improvement initiative. In terms of how they collected the data associated with the costs, I'm a little bit removed from that, so I'm not 100% sure on that. But I know a lot of our data collection is done kind of on a patient by patient survey basis, and that kind of helps us out in tracking how well we're doing.
Right. And when you're assessing the future of the program and how to proceed with this, I'm assuming that you consult that data.
Right, exactly. Yep. And it's not really what I would call like, like a research type of thing. It's more of like a quality improvement realm. And so we're able to look at it that way.
Right. It's always important. Well, thank you for indulging my curiosity on so many things.
Yeah. I wish that I had even more models to share. These are just some of the things that I had seen in my practice, and I'm happy to talk more if anybody would like. You can share. I don't know if there's a spot I can put my email if people are interested.
We can share it with our participants.
Yeah, absolutely. Thank you. I appreciate it.
Yeah. Well, we really appreciate you taking the time to come and speak with all of us today. Oh, and I think, oh yeah. And thank you for your discussion and presentation.
Yeah, no problem.
Yeah, thank you so much. We will wrap it up for today. Thank you everyone for joining us. Feel free to subscribe to our newsletter, visit our website for more news on upcoming webinars, other presentations, that kind of thing. So thank you so much.
All right, thank you. Bye now.